Today we are going to discuss about one of the very important neurological condition known as amyotrophic lateral sclerosis. So here in the amyotrophic lateral sclerosis, we are going to discuss in detail about its introduction and what are the risk factors or maybe the etiology. And also we'll discuss the clinical manifestations, diagnosis, and finally the treatment. Okay, let's start with the introduction, guys. So one point we need to remember that amyotrophic lateral sclerosis is one of the most as well as the worst devastating neurodegenerative disorders. So it comes under neurodegenerative neurodegenerative disorders. It comes under or it is categorized under neurodegenerative disorder. And the usual presentation will be at the age of 55 to 65. So age of presentation will be 55 to 65. And remember one of the very important point that majority of the cases are sporadic. Okay, majority of the cases are sporadic. One of the very important hallmark feature of the ALS is this particular condition has both upper motor neuron as well as lower motor neuron manifestations. So the deficits in both upper motor neuron as well as lower motor neuron is the hallmark of the amyotrophic lateral sclerosis. Okay, but if you see other neuromuscular diseases that usually affect either upper motor neuron or the lower motor neurons, but this particular condition has both upper as well as lower motor neurons. Now, one important point we need to discuss about what are the tracts which are involved in the upper motor neuron. So let us write about UMN. Okay, the two main upper motor neuron pathways involved in ALS are corticospinal tract. Okay, so what we are discussing here, what are the two main upper motor neuron pathways involved in the ALS? One is the corticospinal tract and second one is the corticobulbar tract. Okay, so these two are involved in the upper motor neuron pathway, especially in the ALS. So one thing let us discuss over here, guys. What is the corticospinal tract function? The corticospinal tract facilitates the movement by activating anterior horn cells. So what it will do? Activates anterior horn cells, right? It activates anterior horn cells. So where are these anterior horn cells are located? These are located in the spinal cord. And remember, anterior horn cells belong to lower motor neurons. So the corticospinal tract activate the anterior horn cells which belong to lower motor neurons. Okay, and coming towards the corticobulbar tract here, corticobulbar tract facilitates the movement by activating brainstem lower motor neurons. What it will do? Activates brainstem lower motor neurons. Okay, corticospinal tract activates anterior horn cells which are lower motor neurons located in the spinal cord, and the corticobulbar tract activates the brainstem neurons, that is lower motor neurons in the brainstem. What are they? What it will activate? Actually it is nucleus ambiguous and hypoglossal nucleus. Remember, it activates the brainstem lower motor neurons. What are they? Especially, it activates the nucleus ambiguous as well as hypoglossal nucleus. Remember, both of these lower motor neurons in the medulla are important for talking and swallowing. Talking as well as swallowing. Meaning, so what are the upper motor neuron manifestations will be seen? These manifestations are associated with the corticospinal tract, and these are the manifestations which are associated with the corticobulbar tract. Now, one of the very important point I want to tell you that I already mentioned you here that majority of the cases are sporadic in nature. Familial cases are also seen. Remember this point, familial cases. Familial cases are also seen. Majority of the cases are sporadic, but familial cases are also seen. So remember, the majority of the familial cases of the ALS have autosomal dominant pattern. Okay, MCQ question. Majority of the familial cases associated with the ALS have autosomal dominant pattern of inheritance. And what are the genetic mutations which are associated with this, guys? Okay, what are the genetic mutations? It will be missense mutation. Okay, it will be missense mutation of SOD1. Okay, missense mutation of SOD1. What is SOD1? Is nothing but copper zinc superoxide dismutase. Okay, what is this SOD1? Copper zinc superoxide dismutase. And remember a very important point, guys. This SOD1, a gene present at the chromosome 21. SOD1 gene is located at the chromosome 21. And another point I want to mention it over here, that SOD1 gene is involved approximately in the 20% of ALS cases, meaning majority are sporadic and familial cases are also present. In the familial cases, the majority are having autosomal dominant pattern of inheritance, and the mutation will be missense mutation of SOD1, which is copper zinc superoxide dismutase 1. And remember the point that SOD1 gene is present in the chromosome number 21, and it is involved in 20% of the cases of ALS. So this is what we need to know about the important points regarding the amyotrophic lateral sclerosis etiology. Now let us move on to the morphological features. We have to discuss in little bit more detail here. Morphological features. Let us discuss about the morphological features. In the morphological features, first point I want to discuss it over here is known as reactive gliosis. Have you heard this term, guys? What is the reactive gliosis here? Remember the point that in reactive gliosis, that is, this reactive gliosis belongs to upper motor neurons. So in upper motor neurons, okay, in upper motor neurons, especially the cells which are lost are pyramidal cells and Betz cells are lost. Remember, pyramidal and the Betz cells are lost. So because of the pyramidal and Betz cells are lost, what will happen is there will be a Wallerian degeneration. Okay, you know what is the Wallerian degeneration? The degeneration distal to the lesion is called as Wallerian degeneration, right? So whenever there is a pyramidal and Betz cells are lost, there will be Wallerian degeneration of what tracts? Corticospinal and corticobulbar. I am writing it in a short forms. corticospinal and corticobulbar tracts. There will be Wallerian degeneration of the corticospinal and corticobulbar tracts. Now, whenever there is a loss of neuron, I told you that pyramidal and bed cells are lost, right? Lost, and there will be Wallerian degeneration of the corticospinal and corticobulbar tracts. So, whenever there is loss of neurons, reactive astrocytic gliosis occurs. What will happen? Reactive astrocytic gliosis. What will happen? There will be reactive astrocytic gliosis occurs. Now, tell me, what is the meaning of this reactive astrocytic gliosis? What does it mean by? So this reactive astrocytic gliosis is nothing but it is the process by which the glial cells in the nervous system, especially the astrocyte, proliferate in the areas of the neuronal loss. So wherever the neuronal loss is there, in that particular area, astrocytes proliferate, right? So reactive astrocytic gliosis. What does it mean? Astrocytes, what will happen? Proliferate. Astrocyte proliferate in the areas of neuronal loss. Remember, this point is very, very important for you to remember. So the first important morphological feature will be reactive gliosis. Especially in upper motor neurons, there will be loss of pyramidal and bed cells. Therefore, there will be Wallerian degeneration of the corticospinal and corticobulbar tracts. And when there is loss of neurons, reactive astrocytic gliosis occurs. So what is the reactive astrocytic gliosis? It is nothing but it is a process by which the glial cells, especially I'm talking about the astrocytes, right? Astrocytes proliferate in the areas of the neuronal loss. So first morphological feature will be reactive gliosis. Now let us discuss about the second one. Okay. Second one is the thinning of anterior nerve roots. Second important morphological feature will be thinning of anterior nerve roots. So, what are the anterior nerve roots? Let us discuss about the anterior horn cells, which are present in the spinal cord, right? So, anterior horn cells are the lower motor neurons in the spinal cord. And what is the function of these anterior horn cells? Let us write over here. Anterior horn cells. So what are the anterior horn cells? These are nothing but lower motor neurons. Where they are located? In the spinal cord. Lower motor neurons in the spinal cord. And these anterior horn cells gives direct nerve supply to the muscles of the arms, legs, and also paraspinal muscles. Right? So we know that second important manifestation, I said that it is a thinning of the anterior nerve roots, and I said that anterior horn cells, right, are the lower motor neurons present in the spinal cord, and these directly supply the muscles of the arms, legs, and the paraspinal muscles. So here in ALS, what will happen is there's a progressive degeneration of these cells. There's a progressive degeneration of anterior horn cells. So then what will happen? There will be a thinning of the anterior nerve roots. There will be thinning of the anterior nerve roots. So what will happen, guys? What will happen? Thinning of anterior nerve roots. So this is the another important morphological feature what we will see in the ALS. First one is the reactive gliosis. Second one is the thinning of the anterior nerve roots. Let us discuss about another third morphological feature over here. Third morphological feature will be Bunina bodies. Bunina bodies. Okay, this is another very important, or we can say the pathological hallmark of ALS, especially in the lower motor neurons. So Bunina bodies are present in lower motor neurons. So Bunina bodies are the pathological hallmark in the lower motor neurons in the ALS, guys. Okay, so these Bunina bodies are like helpful to identify under the microscope. They are present in the lower motor neurons that are spared. Generally, we said that lower motor neurons are actually lost. They are like degenerated. But these Bunina bodies are present in the lower motor neurons that are spared. Okay. And what are these Bunina bodies? These are nothing but, okay, PAS, periodic acid skiff. Periodic acid skiff positive. These are nothing but eosinophilic intracytoplasmic inclusions. What are they? These are nothing but eosinophilic intracytoplasmic inclusions, which are PAS positive, meaning periodic acid skiff positive. And so these are thought to represent autophagic vacuole remnants, we can say that. Okay. And in these Bunina bodies, two important proteins are found. In these Bunina bodies, two important proteins are found. What are they? The first one is the cystatin C. Cystatin C. And another protein which is found in the Bunina bodies is the transferrin. Okay, these two proteins are found in the Bunina bodies. Okay, and I told you that Bunina bodies are the pathological hallmark in the lower motor neurons. So this is what we need to know about the morphological features. So after discussing morphological features, let us talk about clinical manifestations. We have quite a big list here. Clinical manifestations. Okay, clinical manifestations. First, let me write about upper motor neuron. Okay, upper motor neuron lesions. So upper motor neuron lesions causes, we know this, spasticity, right? Spasticity, weakness, and there will be hyperreflexia, and there will be a positive Babinski sign, right? Positive Babinski sign. Because I'm not explaining in detail because the lecture will be lengthier. You know, in the upper motor neuron lesion, there will be spasticity, there will be weakness, hyperreflexia, positive Babinski sign, and also another very important manifestation will be increased muscle tone. We know there will be a flaccid paralysis, what we'll see in the lower motor neuron lesion, and the spastic paralysis in the upper motor neuron lesion. So there will be increased muscle tone, or there will be hypertonia. Okay, yeah. So these are the important manifestation of upper motor neuron lesions. And what about lower motor neuron lesions? What about lower motor neuron lesions? This also causes weakness, especially atrophy. Okay, atrophy. There will be hyporeflexia. And there will be muscle hypotonia. Right? There will be muscle hypotonia, and there will be fasciculations. There will be muscle fasciculations. So what are the fasciculations, guys? Fasciculations are nothing but, we know that these are the involuntary muscle contractions that can be visualized as disorganized muscle twitches, we can say. So involuntary muscle contractions, or that can be seen in the form of disorganized muscle twitches, are called as fasciculations. So these are the main important manifestations what we'll see in the upper motor neuron lesions as well as the lower motor neuron lesions. So now we have to study about some of the like core manifestations, like we have pseudobulbar palsy as well as bulbar palsy in the amyotrophic lateral sclerosis. So let me write about this also, because it's very important for us to discuss. First one is the pseudo bulbar palsy. Okay, pseudo bulbar palsy. Remember, pseudobulbar palsy is due to degeneration of the corticobulbar tract. So what is happening here? There will be degeneration of corticobulbar tract. There will be degeneration of the corticobulbar tract. So therefore, because of this, there will be dysarthria. Okay, there will be dysarthria, dysphagia, and pseudobulbar effect, okay, which is also called as PBA, pseudobulbar effect. So remember that patients are progressively more difficult to understand and eventually are unable to swallow food without risk of aspiration. That is what mainly we will see in the pseudobulbar palsy. So in the pseudobulbar palsy, there will be degeneration of the corticobulbar tract, associated manifestations like dysarthria, dysphagia, and PBA called as pseudobulbar effect, and patients are progressively unable to swallow food without risk of aspiration, right? So this is one of the important manifestation. And let us discuss about like another manifestation called as bulbar palsy. Bulbar palsy. Okay, let's see what is this. So bulbar palsy is mainly due to lower motor neuron degeneration of the medulla. So what it will be? Lower motor neuron degeneration of the medulla. Remember this point, lower motor neuron degeneration of the medulla. We know this. What are the like nucleus which are involved, guys? I have already mentioned about this. What are the nucleus which are involved, especially in the medulla? It is nucleus ambiguous, right? Ambiguous. And next one will be hypoglossal nucleus. Nucleus ambiguous and hypoglossal nucleus. So what is the nucleus ambiguous here? It is a motor nucleus of cranial nerve 9 and 10. Motor nucleus for cranial nerves 9 and 10. And what is the hypoglossal nucleus? It is a motor nucleus, same motor nucleus for the cranial nerve 12. Nucleus ambiguous is nothing but the motor nucleus for the cranial nerve 9 and 10, and hypoglossal nucleus is a motor nucleus for the cranial nerve 12. So what will be the presentation, guys? Okay, presentation will be similar to that of the pseudobulbar palsy, but the patient have lower motor neuron findings, especially tongue atrophy and fasciculation. So what are the main important manifestations? Same as pseudobulbar palsy. But what are the like important manifestations here? Okay, but the patients have lower motor neuron findings. Okay, patients have lower motor neuron findings. What are they? Tongue atrophy tongue atrophy because of the involvement of the hypoglossal nucleus, right? And fasciculations. And fasciculations. Okay, guys. So we have discussed about upper motor neuron manifestations, lower motor neuron manifestation. Specifically, we have discussed about pseudobulbar palsy, bulbar palsy. Okay. Now, after knowing this, let us see what are the earliest manifestations and what are the late manifestations of this disease. Okay. So, what are the early manifestations? What are the early manifestations? So, remember the point that approximately 80% of the patients initially presents with the symptoms affecting cervical, thoracic or lumbar areas. Okay, so 80% of the patients presents with symptoms initially. I'm talking about initially. Okay, symptoms of cervical, thoracic or lumbosacral areas. And especially these patients presents with asymmetrical weakness affecting hands, arms and legs. Because of this, there will be asymmetrical weakness affecting hands, arms, legs. Asymmetrical weakness affecting hands, arms and legs. And this usually manifests as unilateral foot drop or hand weakness. This is how the presentation will be. Okay. And also these patients with ALS will also notify difficulty with fine motor skills, for example like picking up a cup or writing with a pen. So this is how the manifestations what we can identify as a early symptoms. Okay. So I told you that 80% of the patients initially present with the symptoms affecting the cervical, thoracic and lumbosacral area. So what about the 20% of the patient, guys? What about the 20%? 20% of the patients of the ALS, early symptoms will be bulbar symptoms. Bulbar. In only in 20% of the cases, early symptoms will be bulbar symptoms known as bulbar onset ALS. If any patient who has the initial symptom of bulbar manifestation, then we call them as bulbar onset ALS, and this condition is primarily manifested with the symptoms of, we know this, dysarthria, dysphagia, because of the effect on the bulbar musculature. And we know, especially in the bulbar onset ALS, the brainstem lower motor neurons are damaged, and patients with this initial presentation will present with difficulty in swallowing and speaking, that we have already studied in the bulbar palsy as well as in the pseudobulbar palsy. So remember, in the early manifestations, 80% of the manifestations will start from the cervical, thoracic or the lumbosacral areas, but only 20% of the patients initially debut with the symptoms of bulbar manifestations. Okay, these are the early manifestations. Let us talk about the late manifestations. Let us talk about the late manifestations over here. So remember that regardless of the initial presenting symptoms, the disease will progress and both upper motor neuron and lower motor neuron deficits will be present. So therefore, whether it is like initially starts with the bulbar palsy or initially starts with the cervical, thoracic or the lumbosacral areas, whatever it may be, regardless of the initial presenting manifestation, the disease will progress, or I can write it as progress to both upper motor neuron as well as lower motor neuron manifestations or deficits will be present. So generally in these patients in the late manifestations, what will happen is the muscle size, there will be a gradual atrophy, right? Progressive atrophy, muscle size and strength strength begin to decrease drastically. Okay, and also the patients will experience muscle fasciculations. Okay, muscle fasciculations. And subsequently, what happens in the later stages of the disease, in the most severe forms, respiratory muscles, respiratory muscles will be affected. So whenever respiratory muscles are affected, there will be difficulty in breathing. There will be difficulty in breathing. So, and also there will be predisposition to the development of respiratory infections, and eventually the patient has to depend on the mechanical ventilation and eventually leads to death. So the last muscles which are generally going to be involved in the later stages of the disease will be respiratory muscles, and there will be difficulty in the breathing. So these are the important manifestations of ALS. Now let us talk about the diagnosis, guys. Diagnosis of ALS. Remember that the diagnostic criteria has been established for the ALS, and it is revised by the L. Escorial World Federation of Neurology. Okay, so I'm telling you the diagnostic criteria as per the L. Escorial World Federation of Neurology. Okay, L. Escorial World Federation of Neurology. So we should have like three important like features must be there. So there should be evidence of lower motor neuron issues. So there should be lower motor neuron issues which must be diagnosed, by, okay, by clinical, which must be clinical, electrophysiological, okay, electrophysiological or neuropathological examination. Okay, so lower motor neuron issues must be present, must be diagnosed by the clinical, electrophysiological and neuropathological examination. Okay, and second criteria will be evidence of lower motor neuron lesions, lower motor neuron issues or lesions which must be diagnosed by clinical examination, which must be diagnosed by clinical examination. And last will be progressive signs and symptoms. So the disease must be progressive and progressive signs and symptoms must be evident. Symptoms and signs. Progressive symptoms and signs. So this is the diagnostic criteria, guys. But remember that some functions that are spared in the ALS that may not be spared in other motor neuron diseases. Okay, especially this is very important for the differential diagnosis. Some functions that are spared in the ALS but may not be spared in other motor neuron diseases. So what are spared? Let us write here, spared in ALS but not in other motor neuron diseases. What are they? Sensory functions, sensory functions. We never studied this in the clinical manifestations. Bladder and bowel functions. Bladder and bowel function, these are also absolutely normal in the ALS. Ocular muscle function, ocular muscle function. Okay, so all these are spared in ALS. Okay, this is about the diagnosis. Now finally, let us conclude our discussion by discussing about the treatment. Okay, so the first one will be riluzole. Very, very important for the MCQ point of view as well as for the exam. So riluzole is one of the treatment, or we can say at present is the treatment of choice for the ALS. And what is this riluzole? Riluzole is a non-competitive antagonist of NMDA receptor. So it is non-competitive antagonist of NMDA receptor. Okay, NMDA receptor. In other words, in simply we can say that what it will do, it blocks glutamate. That's what it is, right? Whenever we are talking about antagonist of the NMDA receptor means it blocks the glutamate. So riluzole is the drug of choice or the treatment of choice at present for the ALS. So remember that it cannot arrest the underlying pathological process. There will be pathological process will continue to go, but what this drug will do is only it may prolong the survival and the time to tracheostomy or mechanical ventilation, or prolongs the death indirectly we can say. And it has some of the like common side effects like dizziness, nausea, weight loss, and also there will be elevated liver enzymes as well as the skeletal weakness. So this is what we need to know about treatment. Some of the other drugs are also which are present like edaravone. They are also approved by the US Food and Drug Administration. But still, as of today, we can say that for the examination point of view, riluzole is considered to be the treatment of choice. And by this, we have completed the topic called as amyotrophic lateral sclerosis.